Right. Good afternoon, good morning, good evening to everybody, depending on what time zones you're coming from. And welcome to this time's Tea Time Talks with MDRP session, where we are discussing state of the art under EU MDR. And if you've been somebody who's been working on the regulatory side with medical devices, this is familiar to you. You know what state of the art is. But there's still a lot of lack of clarity as far as what goes into state of the art section is concerned. It is a prime section in a clinical evaluation report that's supposed to show to the competent authority that your device is safe and effective. And the whole benefit risk scenario that you have going for every device, this whole discussion becomes about the clinical evaluation and state of the art. So here we are with Stefan. And Stefan, I'm so happy to have you here. And before we get into the whole discussion, just a quick introduction, please.
Sure. Hello, I'm Stefan from Beyond Quality. I do a lot of things with the regulations. That's my main lecture already since the last 25 years. So I do not look into other books except the telephone book because there's a lot of funny numbers. And I'm happy to try to share the information I got, my knowledge with as much as people as I know and as I can contact. For me, that's about that we can achieve better devices, more safe and effective devices together. That's why I want to give my information to others and hope I can receive informations back.
Excellent, excellent. And we're really happy to have you here. And without further ado, I think we can go right into our topics of discussion.
Sure.
Okay, so state of the art. Everybody knows what this is about. You have to prove that your device and the technology is contemporary and it's not obsolete. So I think the first thing that come to mind is people often say that your clinical evaluation report as a whole is product oriented, where you're talking about a specific product by a medical device manufacturer. But the section on state of the art is more therapy or technology oriented. So do you have any pointers in that? Like, how do we interpret this?
Yeah. State of the art is a precise and a very cool term, which was not implemented by me or by the MDR guys. It was implemented by the IMDRF guys. So they had the idea about, okay, how to deal with, leverage a device. So if you want to have a device on the market, it should be available. It should be something positive, and it should not be the worst one. So if you think about how to handle a human body, you should be always on the state of the art. So that means it's an acceptable clinical practice, or it is some kind of procedure you already have on the patient management, for example, which a leveraged healthcare environment. It does not mean that it always must be the most advanced solution, because that will be state of the science, not state of the art. So you need to consider that, and mostly it's dealing a lot about claiming state of the art by medical and indication based, but you also need to tackle as the technical parts. I'm an engineer. I go on the technical parts more in a more nicer ways than I would go on the medical parts. So for me, it is also comparing devices in the technical section as state of the art and comparing it to the current practice, and that is what you need to give for the notified bodies and for the authorities, to give them a way to say, okay, you have everything included to be on the best described way and not only on old-fashioned technology.
Right, exactly. And I think also, like in our team, we work with a lot of medical device manufacturers, and we write a lot of clinical evaluation reports also. And it's very important as a medical writer to understand that your state of the art, you're actually trying to say that the device, when I'm using it, and the principle that it is based on, is something that is comparable to the standard in that particular field. So you're talking about a different disease condition, and what are the different therapies by which you can treat the disease condition. So you have to be able to show that my therapy on my device is comparable to what is considered standard here and what are the alternatives, right?
Exactly. It's choosing the current general acknowledged practice on a specific indication or a medical intended purpose or a medical use or a claim, whatever. So you want to go to state of the art to be that level, which is generally available. Not considering that state of the art is your foundation, it's just a basis. You could also go on top on state of the art and tell, yeah, you're much greater, you're better than state of the art, which is pretty fair, actually. But you should at least have the state of the art covered, because state of the art is your minimum bar you need to jump.
Exactly.
Actually, this is the minimum bar also if I go to clinical evaluation.
Right. Okay, so before we move on to the next question, just quickly checking, does anybody in our audience have any points to add over here? Or should we proceed? Okay, I guess we can proceed. Stefan, so moving on. Now, like you said, we work with a lot of medical device clients, and there are some clients who come to us and they say that they want a separate literature search done for state of the art only. While there are other clients who always say we should have one literature search for the entire clinical evaluation report where you're bringing in your subject device, equivalent, all of that. What do you prefer? Do you have a preference?
It is a clear, it depends. You need to have a strategy. You have a device. Your device has a purpose. You need to fulfill everything on every single step on that purpose. For me, what I normally do is I try to slice that purpose. So slicing it first into the state of the art. What is generally available? I can take guidelines. For example, in Germany, where I came from, we have a lot of S3 level guidelines. So those are huge. So they have an extreme high publicated quality. You can use them. They are, in Germany, they are, well, written from God. So that is what they actually has as content. So no one can ever justify or can ignore this kind of guidance. It's never possible in Germany. If it's outside of Germany, you can. You have that as a basic level. That is one thing, but you all need to do it in a strategy. You need to do it in complete ways, state of the art, literature search, the protocol in different, what I prefer, in different documentation sets to make it easy to be interchanged, to be also better used. Because normally a manufacturer has more than one product. And if you have more than one product, you could utilize, you make smaller little searches, good profiles based on a specific indication, and then you can slice it, utilize it in different documentations. That's easy, that's smarter to handle, and it's also smarter to read because no one wants to read a full set of documentation. So that's something which I think it's pretty important for all of us to understand how we can slice a clinical evaluation. So state of the art clinical evaluation plan is fixed. It is as it is. So state of the art is part of it. And then when it goes on the searches, on the search literatures, on the protocols, you can do smaller ideas which you have in your clinical development plan defined. You can do that in a one-by-one literature papers. It's also cool because mostly many people who have scientific evaluation documentation created during the clinical evaluation, they can publish more papers with that. That's cool for them as well because it feels great publishing a lot.
Exactly. And also for state of the art, I feel like, of course, it depends on the devices, but sometimes you have such straightforward devices. And I think authors and manufacturers also need to realize that your clinical literature, the product literature, is going to want to include only those articles that talk about a subject device that have been manufactured by you. Your state of the art, you need to start building on what is the background of the disease, what is your global burden of the disease, what are the different guidelines. And for that, like you said, if you break it down into smaller things, look for guidelines related to this, look for the benchmark devices related to this, and then plan it all out, right?
Exactly. And with the state of the art, there's something which sometimes is forgotten. And that is you have maybe different patient groups. If you have different types of patient, for example, adults and children, and same indications, that might be that the state of the art for children or newborns is completely different than the state of the art for adults. This is something which I see is sometimes forgotten in the clinical evaluation to explain exactly that point. If you have different types of patients, you might have different types of state of the arts. Please ensure that because builds a construct between the patient, the indication, and the advised state of the art, and then you can go on the next step. Sometimes we see that a lot that is forgotten during writing, not by intent, but simply say, okay, we have loads of literature and loads of articles found, and we did not segregate them to the specific patient group. And that is what I think it's personally, it's pretty important, because you can get a lot of non-conformity reports if you do not do. However, it's also depending on how good and how qualified the notified body is in that case. Some are better, some are worse.
Exactly. And another very important point, for state of the art, you can include articles like review articles and your book chapters also, which are generally in the exclusion criterion for your clinical literature. So it's always good to have that kind of demarcation and know how exactly you're going to go ahead with the literature searches for these devices.
Yeah, you can combine all of them. You can combine every possibility you right now have. You can take state of the art. You can take it, compare that with literature. To take also clinical evaluations or studies into your own into account. That's up to you. You need to prepare it in a strategy. And that strategy and the basis with the intended purpose, there comes the right collation of materials you need to dig for. And yeah, the better you have the control about your strategy, the better you will have the control about how to implementing it. And that is therefore clinical evaluation plan topmost document. And you can already exclude and include by state of the art definitions and the declination of the intended purpose of the state of the art. You can very greatly define what will you really need as papers. That is something what I try to do with my team all the time. Actually, I must admit, it will not work always. There are some circumstances, for example, if the product is too generic, like a syringe, you will be out of that idea. But yeah, always remember, if you have this kind of idea, which you have a product without having a real indication of specific target group, you might have a clear look into article 61.10 of EU MDR, bench testing. Maybe that helps you in that cases, because then your claim is state of the art technically, not clinical, technically, and that might drive you. Sometimes it works, not always. Unfortunately, I do not have the option to tell you one approach that will help you in all circumstances. That's why you need a good strategy.
Absolutely. I agree with you on that. It's always about getting creative. It's always about customizing each clinical evaluation, each state of the art discussion. So, completely agree with you. Now, when we're talking about generic devices and not generic devices, a quick question in my mind. So, we've had trouble, I want to say, trying to understand how to put together a state of the art for devices that are used as accessories. Sometimes these accessory devices have their own reports and their own clinical evaluation being done. And I'm talking about devices like guide wires and guiding sheets, which are not primarily used in the treatment, but they are used to deliver devices which are used in the treatment. So, how do you go about thinking of putting together a state of the art for these accessory devices?
That question hits me. How would I do that? For specific accessory devices, I would go to the clinical state of the art and would go on the top level and say, this is our procedure. And I want to support a procedure in that cases, and want to go the way to say, okay, with my clinical procedure, how to use guide wires, how to use guidances with that kind of accessories, with all needed, which I do not need not necessarily for the complete therapy, but for always a part of it, I would go that way and say, this complete procedure would help us in the clinical evaluation. So for that cases where I do not have the opportunity to go directly state of the art on a smaller granularity, where it's just a device which has a clear defined focus, but it is supporting other clinical practice, I need to go on the complete clinical pathway and go on the clinical, and the performance and the I don't get the word now, as a clinical procedure, to make sure I can fix state of the art according to the procedure and not on the device level anymore. That's for me as engineer very hard because it's not my area of practice as an engineer, but I need to ask someone from the clinical team and ask with the clinicals to go, okay, what do you normally do? What is state of the art in here to help you in that way? And then I can produce the clinical evaluation also for accessories in that cases. However, unfortunately, an accessory always has a bit of the weak and weird part in the clinical evaluation, except the accessory is so truly defined that it will be part of diagnostic and therapy.
Right,
Most
exactly.
of them are technical.
And I think I agree. In a way, we have to start looking at it in a granular way, but also the bigger picture. Because even if a device is used as
Yes.
accessory, what is the condition in which it is used? You have to talk about that condition. What are the guidelines for treatment of that condition? And if it's suppose a guide wire which is used in percutaneous treatment, what is the alternative, which is open surgery? How does percutaneous compare to open surgery, right?
Exactly. You speak it right now with alternatives. Alternatives are pretty important to define what I can do. Also, the alternative treatment or the alternative to this to my decided state of the art, because when you, for example, when you look into a few of the devices, there might be different ways of state of the art. There's one which you already prefer, and there's another state of the art which you dislike, because but they same gets into the same idea and same procedure. In the big picture they get the same idea, but in the smaller picture I like the left one more than the right, for example, and then I takes out the one I want and have the alternative. So why is the alternative for me also important? With the clinical evaluation, with that kind of documentation, with the sets and literature I gain, I need to fill my risk diagram, because this is, I outwide in this case is also my benefit risk and my risk acceptance policy. And this is important then, because then I have different state of the arts and I need to challenge it according to different opportunities. And that is a lot of fancy work, which I normally do with giving all the information from that, both clinical strategy ideas and summarizing them into a risk diagram. Normally I give that to students because that's counting a lot from papers, and I don't like to do that.
Right,
But
absolutely.
that's something, yes, you're right. You're absolutely right. We need to also concern about the alternatives.
Right. Yes. Okay. Any thoughts on this? Anybody else?
Just one question, like for this accessory kind of devices, for us for a background section, it's very difficult to find literature in the current because it's already a well-established technology, right? Because we will not be able to get the current literatures to prove our accessory kind of devices. So what will we do in that case? We have to give the background for the therapy for which it is indicated, or what to go about it.
Okay. The funny thing is about a well-established technology is go to a notified body and speak with them if they think this what you're doing is really a well-established technology. We had with them loads of really weird and wicked discussions about what is a well-established technology. And no, as a manufacturer, you cannot say it's a well-established technology, and we as a notified body cannot tell you that's that's a well-established technology. There we are only so mostly have the discussions with one specific notified body who has that kind of problems more than the others. And but therefore we have a nice guidance document, the MDCG 2020-06, which gives you a lot of this kind of information. And for your cases in the as an accessory, I would take into account the full picture, as Anushree already said, takes a complete picture of the clinical practice and the indications and the claims you want to fulfill, even with accessory, and then slice it to your need down what is transported by you or what is dealt in your device. That would be the idea about state of the art for you specifically.
Right, absolutely. And to add to that, when you're working with such devices, I think another thing that we need to remember is often, of course, we'll always have a time frame for the review articles that we want to look at in SOTA. But when it is a technology which has been established for a very long time and there are no current papers or chapters which are discussing it, I think it's always okay as a writer to make an exception add a clear justification saying that since it is a technology that has been in the market for decades now, the current literature time frame did not identify any articles which were speaking about the technology in general. Therefore, an ad hoc search was performed, and some articles from a different time frame outside of this time frame were included. Because it's always good to have a discussion and not say that we could not find information during this time frame. Just go back and get it and add a disclaimer, I would say.
That's a good point. For example, what I directly had in mind was defibrillation technology. Defibrillation technology is extremely old. It's nothing very new. However, with especially the AED devices, we'll get a class 3 devices now with EU MDR. Therefore, you need to have some kind of own data. However, defibrillation is quite old, so it's well established already. But then you need to look more specific what has changed within that time. You had in earlier times, you had a monophasic impulse technically, and now you have a biphasic impulse with less energy, or which is now energy controlled or whatever, time triggered. And this, so also that kind of state of the art changes during a well-established technology. So technology is old, implementation of the technology has changed. So it's now hard to say what is the well-established technology and what is the state of the art. That is now in that cases, and yeah, as you said, nailing it down to which kind of time frame you want to go for. So you can also exclude time frames which are not relevant for you, or which you can do on a specific conditions because of area, because of timeline, because of specific incidents happening there. So it can be a good possibility to make sure you can get on only to the relevant pieces you need to go.
Right, exactly. And also, like before we go on to the next thing, I think a good advantage in all of this analysis is that it's all objective. So it's not about what you feel is right or wrong. It's more about just being able to present what's already in the literature. So if you're able to present that in an honest way and add your conclusion to it, but basically understand it, present the objective evidence, and then add what you feel you could deduce from it. That kind of an honest discussion in a CER, I think it's going to be receptive, right?
Yeah, exclusion criteria. Exclusion criteria. What do you want to exclude and don't want to show to anyone else? Yeah, definitely do that in each kind of clinical evaluation when you already write your ideas about what you want to search, you need to write down what you do not want to have. So you should have clear, already predefined exclusion criteria for specific literatures and specific articles or specific sections of articles, which can be changed later on as well if you are doing the literature search and then you see, okay, these kind of articles will lead you to nowhere, then you remove them from your list. That's still possible, and that's something you should always think about, because you have your main objective to get a valid clinical evaluation by exploring all options you have and make sure you get the best possible treatment for the patient or diagnosis for the patient, and not doing it for the paper only.
Yeah. Yeah. Okay. Now, I have two very important points to discuss that are remaining in this session. I think the first one, which is sort of a bone of contention between lots of manufacturers and the notified bodies also, is how state-of-the-art is used to determine the safety and performance objectives for your device. So in a clinical evaluation, you have a device and you're trying to say that this device is safe and effective, and you're performing a benefit risk analysis for it. And state of the art becomes your source literature, and you take performance and safety outcomes from your state of the art articles, and you devise the performance and safety objectives for your target device. And these objectives you compare with your clinical literature that you've received on your target or equivalent device, and you see whether the complications that are reported in your device, qualitatively or quantitatively, you compare with what has been reported in state of the art, and you use that to justify that your device is not giving you like some new complications and the benefit risk profile is acceptable. So do you have any thoughts, Stefan, on how state of the art literature can be used for safety and performance objectives?
Yeah, if you have a good literature, and state-of-the-art explanations of your device, of the procedure, then you go back exactly on that step and see, okay, can you utilize them for safety and for effectiveness? There are a few scenarios where I often use it. The first one is I have a good standard for my device, because once I have a good standard for my device, I might have essential performances or clinical performances. These are, for example, for all medical electrical equipment in the 60601-2 series. So you always have essential performance. This one gives you qualified quantitative and qualitative criteria what the device needs to fulfill to be state of the art. State of the art, not state of science. So it's still old, but it's old. It's still old, but it's young enough to be state of the art. So with that information, you can check technology, you can check in the information from the technical parts. You can still go on the way to say your device is technically completely safe and effective. But, and there's always a but, state of the art is not sufficient on the overall systematic, because then, you know, yeah, technically it's claimed, technically it's all safe, it's effective on that cases. However, then you need to go still on the way to go against your claims and your medical claims, your clinical claims. Those are also the ones you need to fulfill. And maybe, for example, when I go back to defibrillation technology, I have a real criteria of sensitivity and specificity, which I need to go. And with that criteria, I can say, yay, I fulfill that. So I can be a defibrillator and all is good, but it does only does work on a small amount of devices, only a real small amount of devices where you have this kind of architecture within the standards to get all of this information. So always consider you have a technical part, maybe a standard with essential performances where you claim safety and effectiveness according to the standard, and then go back again to the overall situation and go on the clinical topics, because you do not get clinical topics by a standard. Normally you don't. No, but therefore you can maybe take the state-of-the-art guidelines, the clinical practices, the clinical routines which you are utilizing, or what sometimes also helps for state-of-the-art. There are many associations of physicians, of doctors in worldwide on each country level or each area level who have a few opinions, and these physicians' opinions, if they are qualified on a bigger scale, those are state of your current practice and therefore state of the art as well. Think about if you can get a lot of them, for example, for implantation or something like that, that's common used, or for infection diseases. There you have a lot of guidelines which go directly on the clinical indications, and therefore you have state of the art based on the clinical setup and therefore in the clinical practice, and that will help you a lot.
Right. Absolutely. Absolutely. Okay. Any questions from anybody on this topic before we move on to the last topic for this discussion? All right. Moving on. Now, this is my favorite. So when I look at clinical evaluation reports, the first thing that I look at is state of the art and what is the conclusion that is drawn in the state of the art. And a lot of times I see that writers extract information from literature articles, they put the summaries over there, and the conclusion is, therefore, based on the aforementioned discussion, the device is state of the art. Whereas I always say that there has to be a critical analysis where you identify that these articles which used our therapy provided positive outcomes, but there were these articles that provided negative outcomes as well. So what do you say about that?
Yeah. Actually, when I read a clinical evaluation, I also look first at the state of the art, because that's the only section I understand, because it's technical. Most of the doctor stuff and physician stuff I don't understand. So therefore, for me, it's quite hard. I challenge that exactly in the same way. I go, okay, I know which level, which bar I need to jump. When I know that bar, I want to have from a manufacturer, I want to have explained how to jump over that bar and which kind of height of the bar you have, which kind of weights you have on your feet, which hold you down on earth, and how you can jump it. So for me, it is a critical analysis, yes, a comparing against the state of the art. So state of the art is a best bar you need to jump. You don't need to jump. Don't need to jump to the sky. You just need to jump that area. So for me, it is like I've heard a very funny sentence about that. In translated to English, it would be a good horse only jumps the height it needs.
Right.
So you don't need to over-engineer. You don't need to overdo a topic. So take on precisely what you could do. In the state of the art, first thing, I will say critical analysis. You take on the state of the art. Is that sufficiently covered by the literature? Do you found weak points which you say, yeah, my device has open issues or open problems? That does not matter. It can have them. Therefore, you can make post-market clinical follow-up. So it's therefore the procedure is available. Then you go on that step and say, okay, I'm on my bar and I nearly have passed it or I have passed it, and go on the next step above it and say, okay, my device has everything covered and it's completely comparable based on the efficiency of my device according to standards, based on the literature we found and the safety and clinical performance out of that kind of standards. And we had this specific amount found and everything is good. There might be negative sides as well. Hey, if you use, for example, a therapy device, if you have a therapy device, you will have negative impact. That's right. That's by intent sometimes.
Exactly.
For example, it go back to the defibrillation image because it's easy. If you utilize defibrillation, yes, you will have maybe a positive impact. The person is living again. And you might have also a negative impact, skin burns. Those are inherited to that kind of therapy. You will have them definitely, if you want or not. So you need to challenge that. And that is what you need, because I need it again as risk manager in my benefit risk analysis to make sure I can get that sound. So for yes, I'm also looking to the state of the art and want to have a critical analysis according to papers, standards, state of the art, comparing to my now used product. Standards, quite easy because you can check them left to right. I use the same standards, then I'm exactly as safe. Then performance criteria in the standard, left to right. They have performance criteria, I have performance criteria, compare them in a data sheet, left to right, all fun. And then the literature part is the hardest one because there you need to dig into the literature and say, okay, I found this literature, this is impacting the state of the art or this substantiating the state of the art. And then you can fill your critical analysis, and only at that you can say, hey, it's all good or it's all worse.
Exactly. I think we are both saying the same things, basically. Present what is there. It's a benefit risk analysis. That means we understand that your device is not just about benefit, it has risk also. There are times when your device may not work as well as some other technology. Put it out there and then see if you can go back to the articles that are reporting negative outcomes of inferior performance. See if there was anything specific in that. Like the patient population was different. Sometimes it could be that one article dealt with a very young population and another had a lot of comorbidities. So look into all of this, but always perform a critical analysis. In your conclusion, you should write about this, that there were articles in which your device was superior to others, but there were also articles where it was inferior to others, and then provide your judgment on that. And even the medical device manufacturers, if you're a writer, then the manufacturer will also appreciate having this kind of a transparent discussion and then going on to talk about the benefit risk analysis. That's what it's all about.
Right? Exactly. I do it in the same way. Well, not I read it in the same way. I don't write clinical evaluations, but I write benefit risk analysis within my risk management topics. And for them, I definitely need them. And I need also negative outcomes to make an acceptance criteria. Without negative sides, I cannot, if you do not have negative informations in your clinical evaluation, then you will have a big problem, because once you write your acceptance criteria into your risk management file, into the risk matrix, you will find out if no clinically negative side was happened. Then I'm also to be state of the art. It's not allowed for me to have any risk associated with the device. Therefore, I cannot bring the device to market because a device being available either for diagnostic or for CRP is directly inherited to a risk. Always. There's at least one of risk of malfunctioning. And therefore, there need to be negative and positive sides. That's yes. Many companies try to avoid writing negative about in a clinical evaluation because if I write negatives, then yes, I will scrutinize my my patient's benefit, and if I do that, then my device will not be marketed as good as this. No, that's realistic. That's life. If you want to go out of the door or go to the street, you might get caught by a car. That's life. And for medical devices, it's the same. If you want to help someone, you might have some kind of implication on damage. That's possible. In all devices, for example, also the smaller the skin plasters and all of that. So it's the same topic. Yes, it is here for protect your skin in case of you have wounds or something like that. Yes, positive side. Negative side, it might be too fast glued on the skin, so you can have a skin deterioration by intentionally too hard materials. You can be allergic. You can also be unclean or not sufficiently clean in the device. These are risks directly posed. That's what just weird in my mind right now when I think about that. So this is something which you need to consider. But hey, that's it. That's life. And we all need to know, and we all need to live with that. So no worry.
I completely agree. I'm still checking. Any thoughts or questions from anyone?
Yeah, just maybe the small thought from my side, as I guess Stefan already insisted, but I would like to point out, because of the recent stuff, it's really very, very good. Besides having positive, negatives, or as Stefan knows, for risk management, we already always declare residual risks, but there is another small, very tiny, inevitable factor besides this risk stuff. Residual risk is a side effect which is inevitable. You just cannot avoid this. So instead of writing residual risk all the time for everything which is negative, try to differentiate and slice up. It takes a bit of time, and you have to really do a lots of brainstorming. What is your residual risk and what is really is inevitable side effect of this treatment or therapy or the device, and be very open that it is there, it will always be there, and include it in your clinical evaluation, include it in your, I will recommend you people in your risk assessment, risk management reports. Include, it's very beneficial. It's my personal experience and very well accepted, because I wrote 5 lines for a device in a risk benefit analysis that this is not even a residual risk. This is inevitable side effect of the device, but it benefits outweigh this as well. So just a small thought, add that too, along with your residual risks. It's really very well accepted, at least by notified bodies I had till now.
Absolutely agree. Full agree on that, yes.
But it takes a bit of time to differentiate. You may need to talk to clinical people or doctors what they think is really a risk, residual risk, or is a side effect which is inevitable. Even if you remove all risks, its side effect always remains. Stuff.
Absolutely, absolutely. Excellent point, Shalu. I completely agree with this. And I see that Stefan is also nodding and he's in agreement.
Yes, absolutely, absolutely.
Yeah, you have to be really, I can tell you, very creative with risk management reports when you write them. You have, people really do a super job in identifying mitigation control, but when you have to write creatively the report, you tend to only see benefit, and least residual risk. And of course, you have it, but there's a very nice small touch to it, the residual risk, not just inevitable side effects. Just be open about them. Of course, side effects should not be overseeing your benefit. That's true. But if it's as negligent, because then you do not have a control or mitigation for that, because that's the trouble lots of people will face now. If your reviewer is very keen, it's really, you have some things which you cannot mitigate, even with IFU or warnings or something, declare them as side effects, inevitable. And if they don't accept, they will tell you, but I guess they will love it. Because then you are saved from the trouble of defining your mitigations and control steps and proving implementation of that mitigated step. So you will somehow
Yeah, that's
in
a
a
good
very, very
thing.
good shape, because there are few things you can't control or mitigate at all.
You're right. That's a good thing to write. Inevitable side effects, because
Yes,
with inevitable, you cannot do a
do
mitigation.
anything. Yeah.
Yes.
Because if you write residual risk, they will tell you mitigate it till you accept it. Okay, they will
Yeah.
be on your head all the time. So this
Right.
happened to us last year, and I became super, I don't know, but I became a bit creative. I was talking to my dentist because I'm in that business. So I really talk to my dentist quite a lot. And then he just casually mentioned, it's just side effect of implant. Then it occurred to me when I was at his office, I came back and really wrote this word side effect. And then I went through lots of things again. So it came just out of the blue. When you're talking to your doctors or something, they might utter some words which may be very beneficial. So we just included thinking, let's see. Because then I gave it a thought, okay, if it is a side effect, I cannot mitigate it. It's inevitable. There's small things. Like there will
Yes.
be in a procedure swelling when you put a dental implant. You just cannot mitigate that. There will be. Fine. So
Yeah.
no mitigation against that. Fine.
Yeah. You
Exactly.
know, in the past, think around 2010, 2012, or something like that.
Yeah.
We have written risk management reports, and there was a few lines. The first line was, "Yes, I did all my risk management plan set." Second
Yes.
line was, "Yes, there
Yeah.
are no open issues."
Yes.
Third was, and the third line was, "The benefit outweighs the risk."
Risks.
Yes.
Yeah.
And
And done.
then we
Yeah.
signed it,
Yeah.
and all was good, fine. We all
Yeah.
agreed.
Really. Yeah. We wrote a
that,
nice word. Risk
that was the best.
management was carried out according to the defined plan. Yeah.
Yes, that
Wonderful.
was the best.
Yeah. But the new thing is, means if you think now, then after that, it took me a few months to talk to people, to my other colleagues, that yes, of course, if you, there are few things you can't mitigate. So don't put them in residual risk. Where to put them then? So
Right.
it's kind of just
Right.
small input. If somebody likes to do with their, depends on your device as well. Some devices are not acceptable with side effects. So you have to be careful. Do not unnecessarily mention the side effects if there are none. Fine.
Exactly, exactly. I think that's an excellent point, Shalu. And thank you so much for bringing it up because
Thanks.
it kickstarted this whole thought about risk management and what we can call an acceptable risk or a side effect and such. So thank you so much for bringing that into the picture.
Thank you.
Yeah,
Thanks.
it's great.
All right. So, Stefan, I think this was a very interesting discussion, and we've covered all the different aspects of state of the art. And I know that a lot of medical writers as well as device manufacturers are going to be benefiting from this discussion, which was. This is what I like. It was a very casual discussion. We did not have slides, we did not have pointers, but we were trying to understand how to go about the different sections, subsections of state of the art. Any final word before we wrap it up, Stefan?
Final thoughts about state of the art. Well, always consider your practice, always consider biological, clinical, and also technical stuff. The technical stuff I prefer in the most. And then think about what can happen. And Shalou said it in a very good way. That's my favorite word for today, inevitable side effects. I will write that down in my notebook. That was fun. Thank you. I learned a lot today.
Um,
That's
we
great.
learned a
That's
lot,
great.
Stefan. Yeah.
I learned a lot today. Thank you for that.
Okay, great. Thank you, Stefan. This was a very, very interesting discussion, and I too have learned a lot today after talking to all of you here. Once again, thank you so much for being a part of MDRP Tea Time Talks. And everybody who's listening to this video and who's watching us also on YouTube, we are going to come back with the next session of Tea Time Talks with MDRP. Until then, keep learning. Bye bye.
Bye bye.
Thank you.
Bye.
Bye.